Good morning, Barb. Thanks for joining.
Good morning.
Morning, Julian. Hi, Carolyn. Good to see you again.
Morning. Good to see you too.
Hi, Evelyn. Thanks for joining. Hi, Gabriel.
Hi.
Hi.
I want to say hello to Irene. Irene, can you hear me?
Mhm. Maybe multitasking.
Yeah. Well,
So it's 8 o'clock. I'm going to give it another minute or two to allow others to sign on before we get going. Appreciate everyone's patience. Was that simply my computer that pushed me out of the meeting? Yeah.
no, you're in the meeting. I see you.
Yeah, no, I just was bumped out for a minute. Good morning, everyone. It looks like many are now joining. So for the interest of time, we will start. Welcome and good morning. Welcome everyone to the second Journal Club of this year. Today we welcome back Dr. Chandni Chandramouli, Geriatric Medicine Fellow, and Dr. Farid Medleg, PGY5 resident, as our presenters. I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. First, the short presentation from Dr. Chandramouli. Dr. Chandramouli graduated from Christian Medical College, Vellore, India, and completed residency in internal medicine in Pondicherry, India. Her areas of interest include comparative analysis of healthcare systems and exploring the influence of culture on decision-making. She will present this morning the ENGAGES trial, electroencephalographic anesthesia, or monitored anesthesia, and delirium risk in cardiac surgery. Dr. Chandramouli, welcome, and please feel free to begin.
Thank you. Sorry, I'm just going to take a minute. Okay, are my slides visible? Thank you.
Yeah.
Good morning. I will be discussing an article published in the June issue of the Journal of American Medical Association entitled Electroencephalography-Guided Anesthesia and Delirium in Older Adults After Cardiac Surgery. So the ENGAGES Canada Randomized Clinical Trial. I have no conflicts of interest. So for some background, as we all know, postoperative delirium is linked to poor outcomes, including cognitive decline. To prevent it, avoiding deep general anesthesia has been suggested, and EEG suppression is an accepted marker of deep anesthesia. The 2015 American Geriatric Society expert panel recommends using processed EEG monitors to reduce anesthesia depth, although this was based on low-quality evidence. This guideline predates the 2018 ENGAGES trial, which found no reduction in delirium with EEG guidance. A more updated guideline from the American Society of Enhanced Recovery and Perioperative Quality Initiative states that there is insufficient evidence to recommend EEG monitoring for delirium prevention. This recommendation was not without its internal controversy, with 5 dissenters still strongly advocating for EEG guidance. Here's a look at the raw EEG patterns at various steps of sedation. Before induction, the EEG shows prominent alpha activity at 10 Hertz when the eyes are closed and beta activity at 13 to 30 when the eyes are open. During sedation or phase 1 anesthesia, there's reduced beta activity and increased alpha and delta activity. At a deeper level, known as phase 2, alpha and delta activity further increase, resembling non-REM sleep, and this depth is sufficient for surgery. In phase 3, the EEG shows burst suppression, characterized by flat periods of electrical silence mixed with alpha and beta activity. Extended periods of suppression have been associated with postoperative delirium. As we can see, the raw EEG patterns are complex and can be difficult to interpret in real time. And therefore, we have processed EEG monitoring, which simplifies these complex waveforms into numerical values. I'll briefly touch on 2 indices, bispectral index or BIS and suppression ratio. BIS measures anesthesia depth on a scale of 0 to 100, with 40 to 60 being adequate for surgery. And a BIS below 40 suggests potential burst suppression, usually prompting a reduction of the inhalation agent dose. However, BIS is not validated for older adults, and they may actually show higher baseline values. On the other hand, dementia patients may have lower values. This could lead to errors in adjusting the anesthetic dose. Coming to suppression ratio, it represents the percentage of suppressed EEG activity in an approximately 1-minute period, and time periods with SR more than 1% indicate burst suppression. Coming to the minimum alveolar concentration, I'll skip through the wordy definition and mention that practically a MAC value between 0.8 to 1.2 typically indicates general anesthesia. However, lower MAC levels are sort of a gray area and don't always mean that the patient is experiencing awareness. Let's briefly review the key trials on EEG-guided anesthesia and delirium. These are CODA, Sudoku, ENGAGES, and the balanced sub-study. These trials are all single or 2-center studies. I will mention that CODA and Sudoku, the first 2, involve generally healthier patients, while ENGAGES and balanced include more morbid cases. So I apologize for the busy slide here. I'll leave it for your reference and just highlight a few points. The CODA trial targeted non-cardiac surgeries expected to last at least 2 hours, but in reality, with a median duration of under 2 hours, half the surgeries were shorter than expected. Delirium was a secondary outcome, and EEG guidance showed a significant reduction in delirium risk with an ARR of 8.6% and a number needed to treat of 12. However, power calculations were questioned, and many patients received nitrous oxide predominant anesthesia, no longer commonly used, and it's only minimally affecting EEG. The Sudoku trial, partially funded by the BIS manufacturer, found an impressive 14.7 reduction in the primary outcome of delirium with EEG guidance. However, the mean BIS was the same across the groups, and each arm had different sets of clinicians, so stylistic differences may have influenced the outcomes. The ENGAGES trial, which is the predecessor to the current trial, did not find a significant difference in the primary outcome of delirium. Interestingly, though, there was a 4-fold lower 30-day mortality in the EEG group, a finding that remains unexplained. It has been suggested that the reduction in the suppression time from 13 to 7 minutes may not have been enough to show benefits for delirium. Here I want to acknowledge a great academic half-day session we had back in May by Dr. Leandra Amado, who's an anesthesiologist from the University of Ottawa. And it was on a related topic. There we learned that on the basis of observational data, detrimental EEG suppression needs to happen for at least 4.5 minutes. And obviously here it was 13 versus 7 minutes. And therefore that might explain the lack of difference in ENGAGES. Finally, the balanced trial, a sub-study of the East Asia cohort from a larger monthly center study, which looked at all-cause mortality, compared the 2 depths of anesthesia, BIS of 50, which is a lighter plane, versus 35, which is a deeper plane, and found no difference in the delirium rates between the 2 groups. So how about omitting general anesthesia and opting for spinal instead? As we very well know, the REGAIN and RAGA trials showed that older adults with hip fractures, there was no significant difference in postoperative delirium between general and spinal anesthesia. With this background, let's begin with the ENGAGES Canada trial. The PICO question was, in adults 60 and over undergoing cardiac surgery, does EEG-guided anesthesia, as compared to usual care, result in a lower incidence of delirium during postoperative days 1 to 5? The secondary outcomes included ICU and hospital length of stay, duration and severity of delirium, and 30-day assessment of falls, as well as PTSD symptoms, cognition assessments by the short BLESS test, and quality of life. 30-day and 1-year mortality, among other complications, mainly intraoperative awareness, were also assessed. So this study was conducted at 4 sites: Kingston, Montreal, Winnipeg, and Toronto. Older patients scheduled to have cardiac procedure involving bypass were included. They excluded patients with preoperative delirium, deafness, blindness, if they were neither fluent in English nor French, or had experienced prior intraoperative awareness. The anesthetic agent was chosen at the discretion of the clinician, and the intervention group was encouraged to reduce the dose in response to EEG suppression. So delirium was assessed once daily in the afternoon or evening hours with a cognitive screen, followed by a delirium symptom interview. The determination of delirium was by the confusion assessment method, or CAM-ICU, whichever be the case, and this was supplemented by chart review. The sample size was set at 1,132 patients, assuming a 25% delirium incidence. The CODA and BAG recall studies showed an 8% and 9% reduction in delirium rates with EEG guidance respectively. I will mention here that the BAG recall trial, which is part of a larger study on intraoperative awareness, showed a notable delirium reduction, although it was just shy of statistical significance. So the final sample size was 1,132, and I'll leave the statistical methods here for your reference. Coming to the consort diagram, we see here that the recruitment target was achieved, and the dropout rate in both groups was fairly low. I'll come to the baseline characteristics. So the two groups were similar at baseline with respect to age, sex, and racial distribution. We see that Montreal enrolled the most number of patients, and about 9 patients were from Toronto. Education, alcohol use, visual and hearing aid use were similar between the two groups. Coming to comorbidity burden, the comorbidities as well as the history of delirium, history of depression, and stroke were similar. These were patients with a lot of cardiac comorbidity, obviously, and more than 90% of the patients were classified as ASA4 and above. Assessments for dementia concerns, cognitive abilities, OSA, PTSD symptoms, and quality of life were similar in both groups. I do notice that a proportion of patients with the short BLESS test score 10 and above, which indicates impairment consistent with dementia, was higher in the EEG group, and I wonder if this was statistically significant. The article or the supplementary information does not provide a measure of frailty, nor ADL or IADL performance for the two groups. I would have also liked to see how many patients were on regular benzodiazepines, opioids, and anticholinergics preoperatively. All these characteristics, for example, were reported for the patients in the original Engages trial. Coming to the results. The incidence of delirium in both groups was about 18%, with no statistically significant difference. After adjusting for baseline characteristics, the adjusted odds ratio was not statistically significant, and length of ICU stay and hospital stay were also not significantly different. To put this in context, the lack of reduction in delirium incidence in the EEG-guided group was despite a significant reduction in the time of EEG suppression from 11 minutes to 4 minutes, with a significant reduction in burst suppression periods and a significant reduction in inhaled anesthetic concentration. Importantly, there was no difference in the mean arterial pressure between groups because, as we know, intraoperative hypotension can predispose to cognitive dysfunction. I would have also liked to see data on intraoperative inotrope and vasopressor use, as different agents can affect the cerebral perfusion pressure differently. Furthermore, intraoperative medications such as opioids and propofol, which also suppress EEG, were used similarly in both groups. Coming to the secondary outcomes. There was no difference in delirium severity, duration, incidence of immediate postoperative delirium, or subsyndromal delirium, or 30-day assessment of cognition. There was no difference in the 30-day and 1-year mortality, and none of the patients in either group experienced intraoperative awareness. To address the question of whether only partial effectiveness of EEG guidance might have masked the benefit of the intervention, the investigators conducted sensitivity analyses to determine if the results would change when discarding the quartile of patients in the EEG group with the most EEG suppression or those with the lengthiest periods of BIS less than 40, and they still found no difference. A logistic regression analysis identified risk factors for delirium, including advanced age, higher comorbidity by Euroscore, a history of delirium and depression, anesthesia time, and EEG suppression time. This is consistent with what is already known. Surprisingly, alcohol use showed an inverse correlation, which is at variance with the well-established threefold higher odds of delirium, as we know, with alcohol use. I wonder if this finding was colored by unmeasured confounding variables, such as lower frailty or more active lifestyle in alcohol drinkers. Conversely, could it just be that the patients at higher risk of delirium were underreporting their alcohol use? Finally, this could just be a type 1 error. So to summarize the results, despite a 17.5% reduction in the inhaled anesthetic concentration and a 66% decrease in the EEG suppression time, there was no significant reduction in postoperative delirium in older adults undergoing cardiac surgery when comparing EEG-guided and usual care anesthesia. Other outcomes like ICU stay, hospital stay, and mortality were also significantly not affected. And notably, longer EEG suppression was linked to higher odds of delirium, although this did not imply causation. So the strengths and limitations. The strengths of the trial was that it was well-designed, multi-center, with EEG separation maintained between the groups across the sites. That's something that I cross-checked in the supplementary information. In terms of limitations, the author suggests that the difference in MAC between the two groups might have been too small to impact delirium. Additionally, minimizing EEG suppression might have had a smaller effect on delirium than the 8% reduction that was estimated during trial design. Lastly, including raw waveform analysis alongside the derived values could have provided more insight. So to quickly summarize the critical appraisal, the points I'll make here is essentially, were the groups similar at the start? Yes, they were, but as mentioned, I think measures of frailty and polypharmacy deserved mention in the baseline characteristics. In terms of risk-benefit ratio, while the proposed benefits of EEG-guided anesthesia likely outweigh the risks of intraoperative awareness, a cost-benefit analysis would be needed to see if it would outweigh the cost as well. In terms of whether this was change current practice, I was curious about how often EEG-guided anesthesia is currently used in our centers. A colleague of mine who's an anesthesia fellow at TGH tells me that EEG guidance to minimize anesthetic depth is routinely used at UHN sites for all adults, in fact, and on a case-by-case basis at St. Mike's, and I'm not sure of other sites. Dr. Amado, for example, shared with me that outside of Toronto, EEG usage varies based on individual preferences and monitor availability. It's regularly used in Ottawa. It's also widely used during a total intravenous anesthesia or TIVA, not for delirium prevention, but to prevent awareness because there's no MAC value to guide the depth of anesthesia in TIVA. So finally, until updated meta-analyses and guidelines are published, whether anesthesiologists will adjust their practice based on the ENGAGES studies largely depends on the patient population. Putting the trials together, I got the sense that with increasing comorbidity and surgical complexity, the impact of anesthesia depth and EEG suppression on postoperative delirium may be less significant. This study focused on cardiac surgery, for example, which traditionally has a high rate of neurocognitive disorders postoperatively due to non-pulsatile blood flow during bypass, neuroinflammation, and embolic phenomena. So the results might not apply to all surgical settings. As we've seen, studies do suggest that EEG guidance could benefit geriatric patients in other types of surgeries. Furthermore, the role of EEG suppression as a risk factor for delirium or merely a marker of neurovulnerability is still debated. It's also important to be aware of the limitations of EEG interpretation in the elderly and the real risks of light anesthesia, such as intraoperative awareness. For us geriatricians, these results only further underscore the need for preoperative optimization and proactive multi-component delirium prevention strategies. And so, as we weigh the arguments for and against EEG-guided anesthesia in delirium prevention, the scales of evidence continue to hang in the balance. Thank you.
Thank you very much for an excellent detailed presentation in a short amount of time, and quite a great mastery and understanding of the topic, not just the critical appraisal of the article. And I echo Michael's applause. And Barry notes in the chat box, well presented, excellent background review, makes me believe that we have no understanding of the mechanisms of delirium production. And we have time for one or two questions. I'll open it up to the audience if anyone has a question. And while we wait for others to think of their question, perhaps I can ask, you mentioned that the results might not apply to other surgical procedures. And you did note that cardiac surgery is a relatively high risk for delirium. But I wonder, do you think that a higher risk, let's say a hip fracture population, where the incidence of delirium can be twice what was reported in this study, that may be more effective? And the second question I have is, you mentioned the academic half day a few months ago, where 4.5 minutes, I think, was declared the significant time. And so I believe in this study, even the light anesthesia was greater than 4 minutes in that crucial time. And so how do you reconcile that?
Yeah, so to the first question, to the first question about the hip fractures, I'm not sure if it would apply to that population, especially when trials have shown that, completely eliminating general anesthesia altogether still failed to show a difference when compared with spinal. But I do think that it might be a function more of the fitness and of the patient in question and their own delirium specific risk factors. But of course, coming to the surgery, probably because it's not as complex as cardiac surgery, it's possible that it may show a difference. It's just that the REGAIN trial doesn't give me a lot of confidence that it might. The other question about the 4.5 minutes of suppression, yes, absolutely. The trial group here reduced the EEG suppression time to under 4.5 minutes and still failed to show a difference, which again supports the argument that possibly this is all just a reflection of what the patient is showing you in terms of when they're having EEG suppression. They're just basically flagging to you intraoperatively that they're at high risk for delirium, but maybe reducing that may not necessarily reduce delirium, but maybe a reflection of their neurovulnerability.
Great, thank you. Anyone else in the audience? One other minute, one final question. Yes, go ahead, Natasha.
I actually remember from anesthesia, seeing people with ASA4 is actually quite uncommon. They're very sick patients. They're severe and constant threat to life. That's what the definition is in terms of their comorbidity. Did the trial talk about why they chose such sick people? These rarely, but I feel like this population is actually sicker than my standard patient, which is uncommon in a trial.
That's very true. I in fact looked whether there's data to suggest that ASA classification might be overestimated while making these assessments, because obviously these are patients that they assess to be at a constant threat for losing life. But I think it was because of the cardiac comorbidity that expressly that definition was applied, because a lot of them had obstructive CAD or a recent MI, which for both of them, they would automatically fall under ASA4.
Great. Thank you very, very much again. If the audience has further questions for Dr. Chandramouli, I invite you to post them in the chat box, and we will move on to our long presentation from Dr. Farid Medleg, PGY5 resident, to present to us on blood biomarkers for the diagnosis of Alzheimer's disease. Farid, welcome, and you're welcome to share your slides and begin.
Are we okay with the visuals and the audio? Perfect. Thank you. Good morning, everybody. My name is Farid. I'll be presenting today on blood biomarkers to detect Alzheimer's disease in primary care and secondary care. I have no conflicts of interest to disclose. Let me just move my camera bar over. Okay. So the objectives of today's talk is going to be to review current technology for biomarker assessment of Alzheimer's disease and Alzheimer's dementia. We'll go over the PICO methods and results, and then we'll have a bit of an extended discussion about these results. We'll go through the critical appraisal, and then we'll discuss the implications for practice, and I'll invite other people to jump in at that stage because I myself have a few questions for the implications for a study like this. Before getting into the technicalities of the study, I just want to highlight, the most common and well understood diagnostic criteria for dementia. This is reproduced by a website called PsychDB, but essentially comes from the DSM-5. And the most notable thing I think about the diagnostic criteria is there are no biomarker or imaging criteria for Alzheimer's disease and Alzheimer's dementia. I will note, however, in this study at least, that when we discuss Alzheimer's dementia or Alzheimer's disease, we're often talking about the clinical disease. And in this paper, they refer to that as clinical Alzheimer's disease. When I refer to Alzheimer's disease on its own or Alzheimer's pathology, that will be indicating either a biomarker through imaging or a biomarker through blood tests or CSF. So I just wanted to lay out that terminology that's coming from this paper before we get started. So just a quick overview of biomarker technology in Alzheimer's disease. Alzheimer's disease positron emission tomography is expensive. As of 2020, the cost for an individual scan in the US was about $3,000. CSF biomarkers are cheaper, but may be difficult for some patients to tolerate or endure. The technical proficiency of the physician in question may also be a limiting factor to obtaining this. Neurofilament light concentrations are another modality through imaging that can indicate neurodegeneration in a patient, but not the cause of that neurodegeneration. And so this has ultimately led to the development of blood biomarkers, which have shown high sensitivity and specificity when compared against amyloid PET measurements. And they also correlate well with CSF concentrations of biomarkers for Alzheimer's disease. However, most people who get a diagnosis are first seen in primary care, and there's a minority of people that are often referred to secondary care to either make a diagnosis or continue with management. And while PET and CSF analysis can reduce the rate of dementia misdiagnosis, these aren't actually available at many secondary care centers, let alone primary care offices. We do know that the lack of accessible testing in this respect for Alzheimer's disease biomarkers is an obstacle to initiating anti-amyloid immunotherapy, which is something that is coming to us very quickly. The most promising plasma biomarker so far is phosphorylated tau 217, which I'll be referring to as p-tau 217. We know that it's strongly associated with Alzheimer's pathology in cerebrospinal fluid, AD pathology measured by PET, and neuropathology changes in Alzheimer's disease. The diagnostic accuracy of p-tau 217 improves when it's combined with amyloid beta 42:40 ratio. When these two scores are combined, it's referred to the amyloid probability score 2. I'll be referring to it as APS2 throughout the study. And it also shows comparable diagnostic accuracy with CSF biomarkers in those with cognitive impairment, which is usually going to be the patients that we encounter. So to date, there are no feasible options for serum biomarker testing of Alzheimer's disease in primary and secondary care, and we'll get into why that is later. This goes without saying, but incorporating the results of these tests into the detection of Alzheimer's disease is challenging. And there are many papers discussing the utility of even using these because people can have the pathology inside their blood or their CSF or scans and be completely asymptomatic for many years. This paper will focus on the first point about just developing a feasible blood test to identify the disease or pathology. So which brings us to the JAMA article from July of this year called Blood Biomarkers to Detect Alzheimer's Disease in Primary Care and Secondary Care. So the study question specifically is, can a blood test based on the ratio of p-tau 217 to non-phosphorylated tau 217 combined with amyloid beta 42:40 ratio, when combined, otherwise known as the APS2, accurately identify Alzheimer's disease in primary care and secondary care when used prospectively. And the unique part about this study is when they apply predefined cutoff values to indicate a diagnosis, a positive test, or a negative test. So going over the PICO of this study, the patients were those with subjective cognitive decline, mild cognitive impairment, or dementia based on cognitive test results and clinical assessments. The intervention was the plasma test using mass spectrometry to determine the ratio of p-tau217 to non-p-tau217 expressed as a percentage. This was calculated alone and when combined with the amyloid beta 42:40 ratio, otherwise known as APS2. The controls were CSF values of the amyloid beta 42:40 ratio and phosphorylated tau217. The outcomes, or the primary outcomes, were AD pathology, determined by an abnormal CSF ratio of amyloid beta and p-tau217. Secondary outcomes included the diagnostic accuracy of this blood test with respect to identifying clinical Alzheimer's disease, which is essentially Alzheimer's dementia as identified by an expert panel. And the values calculated were diagnostic accuracy, positive predictive values, negative predictive values, and the area under the curve. So this is a multi-center study of primary and secondary care centers in Sweden. It's a cohort study where the recruitment was for patients to be put into a single batch analysis, and then a second group that was used for prospective analysis with batches collected every 2 weeks. And the reason for this second group was to better mimic real-life practice among primary care and secondary care physicians. To break down what the primary analysis was, there were actually 2 broad groups outside of the primary care and secondary care divisions, and that was applying 1 cutoff value versus 2 cutoff values. In the 1 cutoff value analysis, 1 value was determined where above the value would be positive for Alzheimer's pathology and below would be negative. In the 2 cutoff value group, above the upper range would be positive and below the lower range would be negative, and in between those two would be an indeterminate group. And so they wanted to see if a 2 cutoff value approach could improve the diagnostic accuracy. And we'll see in the 1 cutoff value analysis that in the prospective cohorts, just down here, the values were actually compared against dementia specialists to see how the biomarkers performed against people and not just things like CSF biomarkers or PET scans. In a secondary analysis, the diagnostic accuracy of the blood test was assessed across different levels of cognitive severity. I will highlight that normal cognition outside of subjective cognitive impairment was not included in this study. So all patients included either had SCI, MCI, or dementia. And in this secondary analysis, the data was actually pooled from primary and secondary care cohorts. So on to the results, looking at the patients themselves and their biomarker characteristics. The thing that jumps out to me the most here is patients in the primary care cohort had higher incidence of comorbidities. And the 4 comorbidities identified in this study were cardiovascular disease, hyperlipidemia, chronic kidney disease, and diabetes. Length of education was less among the primary care cohort patients, and the age was older. The one thing I will identify is the incidence of Alzheimer's disease pathology as per CSF analysis was essentially equal between both groups. On to the results of the biomarkers themselves. And so this first table looks at the entire analysis for the 1 cutoff value approach. And you'll see that the 2 graphs on the left are from the single batch analysis and the 2 graphs on the right are from the prospective analysis of samples collected every 2 weeks. And the one thing that stands out to me is the high diagnostic accuracy for the blood test across all of these groups. There is some variation, especially in the specificity of tests, but overall high performance when compared to CSF values. Moving on to the 2 cutoff value approach, you can see a bit more variability in the outcomes, the positive predictive values, the negative predictive values, sensitivity, and specificity. But the one thing I'll highlight is that intermediate group of people, the people that fell below the upper value and above the lower value, range between 5 and 12%, with the APS-2 analysis always having a higher incidence of intermediate values. When comparing the diagnostic accuracy of physicians versus biomarkers, in this arm of the study, they actually looked at primary care doctors and dementia specialists making a diagnosis of AD pathology using clinical assessment and cognitive screens, and compare the accuracy of that against blood biomarkers. And what you'll see stands out here is the performance of the plasma biomarkers is far higher than a human being when doing this assessment in identifying AD pathology in CSF samples and AD PET. The one thing that I found very interesting is the difference in specificity and sensitivity between the dementia specialist and primary care physician, with the dementia specialist catching far more people with an AD pathology but being far less specific, and the opposite being true for primary care physicians. Moving on to identifying clinical Alzheimer's disease. So when the performance of the blood biomarkers for determining clinical Alzheimer's disease, i.e., whether somebody had dementia, based on an expert assessment of a clinical assessment and CSF analysis and PET, we saw that the doctors had a far lower performance score than these blood biomarkers. Now, this was only assessed in patients with MCI or dementia, and patients with SCI weren't included in this wing of the analysis. And then moving on to this secondary analysis, biomarkers were assessed for their performance across different levels of cognitive decline. The standout feature here is looking at the graph on the left-hand side, a much lower sensitivity and positive predictive value in those with subjective cognitive decline, which essentially improved at higher levels of cognitive decline, MCI and dementia. That was the one cutoff value approach. Again, the second half of the analysis was the two cutoff value approach. And you can see again, in subjective cognitive decline, positive predictive values and sensitivity were far lower than when looking at patients with mild cognitive impairment and dementia. Again, looking at the bottom graphs, the APS-2 has a higher incidence of people who fall in that intermediate zone below the upper level and above the lower level that were set for cutoff values. So moving on to the discussion. I believe this study shows that applying predefined blood biomarker cutoff values for the percentage of phosphorylated tau combined with amyloid beta ratios, which is the APS-2 score, resulted in high diagnostic accuracy, positive predictive values, and negative predictive values. This was achieved for both patients in primary and secondary care clinics. The APS-2 performed consistently in the group of patients collected where samples were collected prospectively. The diagnostic accuracy of the blood test surpassed that of dementia specialists and primary care physicians in identifying AD pathology, but also in identifying clinical Alzheimer's disease, which highlights the potential for improving the diagnostic accuracy when assessing patients with potential Alzheimer's disease. Most studies we have now show misdiagnosis of Alzheimer's disease at about 25 to 30%, even in people labeled as dementia specialists. The blood test performed accurately despite a relatively high rate of medical comorbidities, which I will highlight includes kidney disease, which was 26% of the primary care cohort. The improved diagnostic accuracy of the APS-2 and percent of p-tau217 alone was evident when both the Alzheimer's pathology and clinical Alzheimer's disease were assessed. There may be value in plasma biomarkers in clinics where CSF and PET are not readily available, which is probably where most people are being assessed for cognitive decline the first time. We know that the diagnostic accuracy is equivalent to that of CSF biomarkers. And so the question that I would ask the group for contemplation is, could this eventually mark the end of CSF biomarker use in Alzheimer's disease? We saw that the two cutoff value approach achieved positive predictive values of 97 to 99% in patients with cognitive impairment, which is the target population for anti-amyloid treatments. positive predictive values were suboptimal for accurate identification of Alzheimer's disease in those with SCI, regardless of how the cutoffs were modified. However, the negative predictive values remained high in those patients. And so it could be that these tests are actually useful in ruling out Alzheimer's disease pathology when symptoms are either very mild or very subtle. One thing I'd like to highlight is novel methods used in this study that we haven't really seen before on a large scale. First is the use of predefined cutoff values derived from an independent cohort before this study. The use of prospectively analyzed plasma samples to mimic real-life practice, especially in primary care, and the validation of diagnostic performance of blood biomarker data collected from a diverse cohort of patients, including those with multiple comorbidities and those treated in primary care. So moving on to the critical appraisal. Was the diagnostic test evaluated in a representative spectrum of patients? I believe so, aside from the fact that it was limited to one country. However, we had patients across the spectrum of cognitive decline, and the cohort included 4 chronic disease comorbidities that are frequently seen in those with cognitive decline. Was the reference standard applied regardless of the index test result? Yes. All patients underwent plasma analysis and CSF sampling as a control. There were a small percentage of patients who couldn't undergo CSF sampling, and so the alternative for those people is that they underwent AD PET scanning. Was there an independent blind comparison between the index test and an appropriate reference gold standard of diagnosis? In a way, yes. We don't have a gold standard for diagnosis of Alzheimer's disease from a clinical standpoint when it comes to biomarkers, but all personnel analyzing the samples were blinded to all clinical or biomarker data. And then were the methods for performing the test described in sufficient detail to permit replication? I would say certainly yes. The methods is probably the longest feature of this study and is written in quite a lot of detail inside the supplemental section. So I do believe that we could replicate this quite easily in a number of settings. So in terms of generalizability, patients were selected across levels of cognitive decline with various comorbidities, including chronic renal dysfunction. Among the breakdown of diagnoses of people inside the study, non-Alzheimer's diagnoses made up about 25% of those diagnosed with cognitive decline. And so the other diagnoses were things like Lewy body dementia, frontotemporal dementia, et cetera, et cetera. So we could discuss whether this is actually representative or a fair representation of people with cognitive decline across the spectrum of practice that we have here in Canada. However, patient sampling was limited to a single country. And so the comorbidities of people may vary depending on which country we are in or even which continent that we're in. In terms of cautions and limitations highlighted by the study and things that I identified as well, Alzheimer's disease pathology can be asymptomatic for many years. The authors got around this aspect by only including those with SCI, MCI, or dementia, but it would be interesting to know how these blood biomarkers performed in those that were completely asymptomatic to have a baseline. Cognitive symptoms can be nonspecific. So dementia workups may not be well known or well understood in primary care. And so when to order these blood biomarkers would need to be clarified for those who aren't considered experts in the assessment and management of dementia. We know that the 2 cutoff value approach resulted in higher diagnostic accuracy in subjective cognitive impairment and MCI, but it resulted in higher intermediate results. And so the question becomes what to do about these patients. And should we rely on primary care physicians to make that? Or should we have an automatic referral to a dementia specialist if somebody were to fall in this intermediate range? I will highlight that the biomarker analysis of the plasma samples was done by mass spectrometry in this study. To be widely applied, it may be too cost limiting. And so while there currently are mass spectrometry assays in most tertiary care centers, I don't know if they have the bandwidth to be able to take on all the plasma sampling of people with suspected cognitive decline. And how would somebody in a primary care center utilize one of these machines? So in summary, plasma biomarkers using predefined cutoff values do show a high diagnostic accuracy for both Alzheimer's pathology, but also clinical Alzheimer's disease in secondary analysis. The results were consistent across primary and secondary care, as well as across single batch analyses, as well as prospective samples collected every 2 weeks. Feasibility for this approach may be an obstacle for the widespread rollout to primary care. And future studies are required to understand how this could actually affect the clinical decision-making and clinical outcomes of those with cognitive decline and dementia. So the final question is this study practice changing? I would say right now, no, but in the future, it may become so. A few things to address is, while the diagnostic accuracy is superior, how do we implement it while taking into account cost, protocol, and interpretation of test results in people that are experts versus those that aren't experts in dementia care? And so with that, I will open the floor to questions and comments. Thank you very much for your attention.
Thank you very much, Farid, for a beautiful presentation as well. Very clearly articulated, walking through many different data points with different cutoffs. So we appreciate it. Michael has his hand up. Go ahead.
Marvelous presentation. And the question I have is, I know right now this test is being used in research studies to identify people for whom whatever the research protocol is seem to be suitable for the research. But in terms of clinical, I think the risk always is when there's a test available for something and people say, I'd like to know, the real question is, well, what do you do with it? And we've seen that with people going to the United States to get tests done for biomarkers and coming back with results of biomarkers for this and that. And then the physician says, well, what do I do with it? Because most of our decisions about intervention are clinical decisions. So how do you see this, especially since the drugs that we suggest may be potential for future development after 5, 10, 20, 30 years of use? How do you see this being used at the present time?
Just Farid, can you stop sharing your screen just so we can visualize?
Sorry. I mean, I didn't spend too much time discussing this because I think it's a Pandora's box from a presenter standpoint, but I think maybe the most useful application will be the decision on whether to give somebody anti-amyloid treatment. The problem is the effectiveness of that is debated. The availability of that is low. And so I think the real world applicability of a plasma biomarker is very low right now. The one thing I could see it potentially being applied to in Canada or in my practice right now is confirming a diagnosis. There is a certain amount of diagnostic uncertainty, and data consistently shows that there is diagnostic error even among dementia specialists. And so is there a utility in just helping families sort of come to terms with the diagnosis or minimizing that diagnostic inaccuracy? I think there could be, but really it seems like the research is pointing towards the utility of this as highlighting people who are eligible for anti-amyloid care. And I just don't know that the tests are good enough right now. And what to do about it, I mean, for us here, nothing, which is why I don't think it's very useful right now. But yeah, it's a fair question.
Thank you very much. A few comments in the chat box. Katrina says, fascinating, well presented and discussed. Carol has a question. Can you remind me, is anti-amyloid treatment widely available in Sweden where the study occurred?
You know, that's a great question. I actually don't know. I do have a family physician friend there, so I will reach out and sort of see, but maybe a quick Google when I get off this call.
Yeah, and I see here that one of the leading developers of lecanemab is Swedish, Lars Landfelt. And so that possibly has a connection there. Barry, go ahead.
And Professor Ingelsson at Toronto Western is a colleague of his, so that he's starting the clinic at the Western. One historical comment: John McLaughlin, who founded what is now the Memory Clinic at the Western, but was then called the Alzheimer's Disease Clinic at the Toronto General, told in an era when you got a lot more autopsies, told me how in older patients, his accuracy in diagnosing of Alzheimer's disease was terrible. So this confirms that he was not an exception, he was the rule. And it seems to me from the results that you presented the most powerful thing right now is that you can rule out Alzheimer's disease. In other words, you can say you're not a candidate for lecanemab. So I think the real issue, and it will revolutionize research, because there will not be CSF markers pretty soon for the people doing the research. So it will change that, even though it's not changing clinical practice. I get that from Sandra Black. And I think the question is going to be, will we ever get biomarkers that are good enough to avoid that intermediate step of doing a PET scan? And I don't think we know yet, but that's going to be a crucial issue, because that will then limit dramatically the generalizability. We can't even get MRIs, let alone PET scans in Canada at a decent rate.
I completely agree. I mean, I'm hoping to see a protocol where, if all this is applied, the blood biomarker is the first step, and the people getting PETs are only those who fall within an intermediate range in some 2 cutoff value approach. And therefore, you minimize the use for PET, you minimize the wait times, and you can start the blood test in a primary care office. But, again, the applicability of that is in question, because what to do about the results.
Thank you, Barry, for those insights. Karen, I saw you had your hand up. Do you want to ask a question?
Thanks, and congratulations. Actually, both presenters were really, really nicely done. I enjoyed it. Farid, I just wondered what your thoughts were. One of the things that occurred to me was just about co-pathology in dementia. And did the authors talk at all about with advancing cognitive impairment, and with older age, there's a lot of overlap, for example, with Alzheimer's disease and Lewy body and NPH, and how would that affect the utility of these types of tests?
So they didn't make any comments as to whether co-pathology, like true co-pathology, if somebody actually had 2 biomarkers positive, affected the accuracy of the test. There was no discussion of that. They only went as far as identifying what the existing diagnosis was for some patients, whether they carried a diagnosis of FTD or LBD or something like that. So to answer your question, no, there was no discussion about how it might affect the results. My interpretation of them including that in the study is to say, well, look, here's another indication that our diagnostic accuracy might not be that good. However, it's hard to make that conclusion because there was no testing of other biomarkers. And so I don't quite know what to make of it, to be honest with you. And I think the question of whether it affects the accuracy is something for further down the road.
Thank you. Any other questions from the audience? A few more comments. I agree, Barry. Always amazed at the incredible abilities of our trainees. Two superb presentations. And Deborah Brown states the same. Great discussion as well. Carol says, are there data to tell us what seniors, people with SCI want with respect to biomarker availability?
Great question. I'm not so sure, but I do, there was a small subgroup, as I had mentioned, who couldn't undergo the CSF analysis for their control, like their self-control, and all those people underwent PET, which indicates to me that, PET is more tolerable and accessible for some people with limitations who can't undergo a lumbar puncture. I would assume that the blood test, the venous sampling for this is much more tolerable. And so I guess if somebody was forced to choose, most people would pick a blood test, but that data, I haven't seen that data.
I was thinking beyond that too, just generally, do the public want to know, not want to know? If this test was available at your corner store, that kind of thing. Like what is the norm? What are people thinking these days with respect to this and all the news?
Go ahead, Michael.
What I find now that I've returned, I'm working at the Toronto Memory Clinic, is that the people who ask about this are the children. I often have children saying, well, now that my diagnosis is made and my mother, my father, whatever, first they say, what should I do? But then they say, how do I know if I'm at risk And other than getting an ApoE, which means probably nothing these days, and that could be almost be done at the corner store. And you don't know what to do if it's both positive, because you can't tell them what to do. These are the people who I suspect, if the test became readily available, would want to know. But the question then comes up, as we said before, and now what do I do about it, other than what I'm doing now is focusing on lifestyle, which actually has been shown to have a benefit, and that is much more available to most people, even though it may be hard for them to change their lifestyle. I find one of the biggest ones in my practice now is getting people to stop drinking alcohol.
Great, thank you. And other diseases like Huntington's, the majority of people want to know their risk. So with that, I will echo all the comments in the chat box and congratulate both Farid and Chandni for just excellent presentations this morning. What a great way to start Friday. Please pay attention to the evaluation link that should appear in your email inbox, if not already, shortly. And I wish everyone a great end of the summer, and we'll see everyone again in September. Thank you, Farid and Chandni.